So we have four speakers, myself, Dr. Vikram Jain. We also have Dr. Deepak Mishra with us, somebody who needs no introduction, who's been conducting SSTC for so many years in AIOC, 8 years plus, sir? 10 years plus, okay. We have Dr. Ravi Daruka from Sharp Sight Eye Hospital in West Bengal, Asanol, and Dr. Gautami from RIO Bangalore Minto Eye Hospital. I'll be talking about Applanation Tonometry as well as how to set a target IOP. I'll start with the talk on Applanation Tonometry. Now, Applanation Tonometry basically measures the intraocular pressure by providing force which flattens the cornea. It's not always so. It can either be variable force or variable area. Why I put this first is because the most common tonometer, the most accurate gold standard that we use is the Prism Goldman tonometer. This is a variable force. The area, the tip, the size of the tip is a constant. So the area is constant. It is the force that you vary when you turn the knob around. So it basically, the variable here is the pressure that is being applied when you are turning the handle out there. You are going to be using external force to flatten a given area. This is the Imbert-Fick law. That is, pressure within the sphere is equal to the external force needed divided by the area of applanation, the area of flattening. This particular law is applicable to a surface which is perfectly spherical, infinitely thin, elastic. The cornea is none of these. The cornea resists flattening. There is also capillary attraction by the tears which will pull the cornea towards the probe. Now these two, that is the resistance of the cornea as well as the capillary attraction, would cancel each other out when the inner area of applanation is 7.35 square millimeter. This is achieved when the outer diameter is 3.06. Nothing we have to break our head about. It is a constant. We just have to know it. Professor Goldman has derived all this and we are enjoying it to this day. So, but nevertheless we should know it. Why this area was chosen is because these two major forces cancel each other out. Otherwise, like in Shiorts, you'd need a nomogram for each different weight. You'd need a nomogram for each different size of tonometer that is required. So, when the diameter is 3.06 millimeters or the area of applanation is 7.35 millimeters square, these forces cancel out. Goldman tonometer is the most accurate. It is basically two prisms, and what you are seeing, since it is round, the semicircles are the edge of contact. The displacement of fluid is also very minimal and hence unaffected by ocular rigidity. It is the outer edge of the prism that is visible. So to begin with, you set it at around 1 on the measuring setting, that is 1 gram of force. This is because at beyond this, if you start from 0, at around 1 there is a small micro movement of the tonometer. You don't want to cause any trauma inadvertently to the cornea. Therefore you start beyond it, either at 1 or 1.2 marking, that is 10 or 12 millimeters of mercury. You start and then further increase or decrease it depending on what you are seeing. The light should come from the temporal aspect. Around 60 degrees temporal is ideal with the cobalt blue filter and a 10x magnification. Beyond that, if you're using 16x, you might miss sometimes the Myers and you'll end up going front and back. Instill the topical anesthetic, stain the cornea, make sure that the patient's forehead is touching front so that you don't have to go ahead, and if it's not touching front, if the patient moves suddenly ahead, there might be minor trauma. So make sure that the patient's forehead is against the rest and then you move forwards. When the probe just touches the cornea, you will see the limbal glow. That's when you have to slow down. After that, you look through the eyepiece, either right or left depending on how it is set up in your slit lamp. Don't advance too far. The probe might become too variable in size. So this is how your endpoint should be. The inner rings of the superior and inferior should be touching each other. The inner rings should be touching each other, like there. They should not be overlapping, just the inner rings should be touching each other. the width of the mire should be approximately 10% of the circle width. You adjust the tension dial so that you achieve this end point. Mire should not be too thin or too thick. This is an ideal thickness of the mire. If there is too much of fluorescein or too little of fluorescein, you will have thin or too thick mires, which may be giving a false high or low intraocular pressure. So it should not be of different size either. They should be of equal size, not too thick, not too thin. This is when the reading is lower, this is when it is higher. This is a perfect applanation end point. At this point on the reading on the scale, you have markings at 1, 2, 3. So that is basically you multiply it by 10. The next marking would be 2 millimeters each marking. So it will be 12, 14 and so on. There can be a lot of errors in measurement. Two things which are in your control are too thick or too narrow mires. This you adjust by telling the patient to either blink if it is too thick, or restaining if it is too thin. Lot of other errors can be there. This is easily available. This is from the AIO book. One more point which you can control or make adjustments is for very high cylinders, above 3 cylinders. The area of flattening won't be a perfect sphere, it will be elliptical, thereby giving a slightly higher intraocular pressure. In such cases, on the side you have a small red line. You have to align the negative axis on this red line. For example, if these are the K values, the lower value 41 at 30 degrees, you align 30 on the red line in the probe holder. Otherwise, routinely make sure that the 0 and the 1 are aligned. In case of high astigmatism, when the cylinder is more than 3 diopters or you are getting elliptical mires, that's when you have to align this small lower cylinder against the red line. The red line is actually 43 degrees away from the 0 marking. There can be inter-observer variability also. With practice, you would get it better and better. One more error is when it is not calibrated. Every tonometer is supplied with this calibration rod, which has 5 markings. This is the 0, 2 and 6 marking. Okay, make a note, 0, 2 and 6. So what you basically do is align it either at 2 or 6 and then fix it against the tonometer. There is a small receptacle there. Video is not playing. I'll show it then. I'll come back to that video later. Another applanation tonometer which uses the same prism is the Perkins tonometer. Now this is counterbalanced and therefore can be used for children when we are doing an EUA, wherein we cannot use the Goldman applanation tonometer, we use a Perkins. The other applanation tonometers, this is Maklakov fixed force. The different weights are there. You stain the cornea with a dye, measure how much of area is stained on this. Not very in force now, just for completion I put it up. In between patients, make sure to sterilize it. What I do is basically keep a bottle of sodium hypochlorite 10%. I have 3 heads and 2 bottles. After I finish one patient, take it, put it in that bottle of sodium hypochlorite, then clean it with distilled water before I change it on. Just a small duration of even 1 minute is